Okay, let's talk about this cool case of a series of transverse process fractures in an athlete. This was a 31-year-old male presenting with sudden onset of lower back pain that happened during a soccer match. He attempted an overhead kick, which is shown here with some clips from the video. You can see him trying to kick the ball over his head with a bicycle kick. Here he is in the air, and then he lands very awkwardly on his left side. He tried to continue playing, but basically was not able to, so he was taken out of the game. He experienced consistent lower back and left flank pain and very mild shortness of breath. And so he was examined by the team physician, who found him to be diffusely tender over the left lateral lumbar region. Fortunately, the rest of his visceral exam was okay: abdominal, cardiovascular, respiratory. He had a normal neurological exam. He had no saddle anesthesia, no problems urinating or moving his bowels. He had some routine blood work and a urinalysis, no blood in his urine, and his blood work was all normal. He had an MRI which showed edema with left-sided transverse process fractures at L2 and L3. And then, of course, a CT is a better study for this. So he had a CT scan that's shown here. And you can see the coronal. This is the L2 transverse process fracture of the coronal. This is the L3. And then you cut to the axial, and they're showing you the same images in the axial plane. So two transverse process fractures on the left side, L2, L3. So let's talk about those a little bit. So transverse process fractures are typically associated with high energy or violent trauma. And in those patients, they often have visceral injuries or other significant spinal trauma, as opposed to athletes where it's usually a low energy mechanism with rare or infrequent complications. But there's not a lot of data looking at athletes with transverse process fractures. Here's the anatomy. I don't want to review all of the vertebral anatomy, but here's the transverse process, okay? And essentially the lamina comes across from the posterior aspect and the pedal from the pedicle from the anterior aspect, and they come together and coalesce, and then the transverse process spits off the sides in the lateral direction from the vertebral bodies and serves as an attachment site for ligaments and muscles. These patients typically present following some form of trauma with lower back pain. The big thing here is, and with any case with back pain, you sort of have to think about red flag symptoms, right? So low energy trauma, high energy trauma, no trauma, right? Are you peeing blood? Are you pooping blood? Do you have abdominal pain? Do you have any chest pain to suggest a vascular problem? Do you have any neurological deficits, right? Loss of reflexes, weakness, radicular symptoms, not really a red flag. Are you anticoagulated following trauma where bleeding is a concern? Do you have a history of malignancy where maybe you have poor bone quality and you're at high risk of weird fractures? Do you have a history of IV drug use where you may have infection in places where you don't expect infection? So you want a good history. In an athlete, of course, some of these risk factors are sort of de novo negative or default negative, excuse me. On exam, you really want to look for evidence of trauma, right? You want to see if there's any signs of abrasions or injuries to the skin, contusions. Is there any point tenderness over the midline or over the paraspinal muscles, which is what you would expect with a transverse process fracture? And then perhaps most importantly, for any back pain of any etiology, you really just need to do a thorough neurovascular exam, right? So you need strength, sensation, DTRs. A gait exam is really important. To evaluate for transverse process fractures, typically you start with x-ray. This is a very low yield test. Sensitivity is as low as 22%. That's pretty concerning. You miss a lot of these fractures. And so here I brought up some x-rays of a PA view of the lumbar spine with 3 transverse process fractures. You know, the white arrows are pointing to them, but I would challenge you through the bowel gas to clearly delineate where these fractures are. I mean, you can see them. This one may be most obvious, but you know, it takes a keen-eyed radiologist to see those. Without the arrows, it would be much harder to tell. CT is the gold standard. Essentially for any bony trauma, CT is basically 100% sensitive. It gives you 3D reconstruction. You can really see the nature of the fractures. MRI, you don't always need MRI for these. I mean, often that's going to happen just to rule out other soft tissue injuries, but essentially the MRI is looking for ligamentous, muscle, cord injuries, lumbosacral plexus injuries, that kind of stuff. In terms of management, right, these are non-surgical as long as they're isolated. If they have other injuries, they're still non-surgical, but those other injuries could become surgical. So transverse process fractures, universally non-surgical. Basically pain control, and whether you use opiates or muscle relaxants is somewhat subjective, depends on how uncomfortable they are. If they have any other injuries. They do make lumbar corsets, or actually you can have TP fractures in the neck and in the thoracic spine, but they're most common in lumbar spine. Sometimes used for comfort, but the literature doesn't really support their use. And then if the patient really has persistent pain, maybe there's a role for physical therapy here. In the case of our patient, he was managed conservatively, of course. He got paracetamol, which is acetaminophen, ibuprofen, and codeine. And then he started having some muscle spasms, so he was given Valium, which helped. 3 weeks in, he started low intensity activity like cycling at day 57, so almost 2 months or roughly 2 months. He started doing his outdoor training and soccer specific or football specific exercise. And then at day 68, which is roughly 9 weeks, he had a full return to sport. He had no further issues and had uh, competed at a high level consistently after return to sport. So 3 key points about transverse process fractures. The first is they're usually a low energy trauma, such as an awkward landing, maybe some weird torsional force with localized lumbar pain and really no complications. If this is the problem, CT imaging is the gold standard. It's very sensitive, provides very good visualization. MRI is useful for soft tissue ligamentous and spinal cord injuries. Another word, ultrasound, is in there. There is a conversation about ultrasound, but that is not for today. And then the management is non-surgical with rest, analgesia, and early mobilization is tolerated. Excuse me. Bracing is optional, and recovery is pretty quick, with most people able to return to play in about 2 months.